we talked about yesterday. So thickness, not just thickness itself, because we're going to measure that in the anterior, but is there, like when it gets thick, is it uniformly thick, like we saw at ascites, where it was kind of a soggy crouton? Or do we have wall, what we call edema or hyperemia? What are we dealing with in the wall? We might have some inhomogeneity to the wall. Projections, we're going to talk about some pathologies, and then it's just general appearance. And then it's going to vary with distension. So if my patient is NPO, then they're going to have a very thin, enlarged, not enlarged gallbladder, but a large slug with a nice thin wall. But if it's contracted, they just eat, and it's going to become a little bit thicker. So we need to know our NPO status on our patients. The lumens, so we're looking at things in the lumen, obviously, and then we're going to see if there's any shadowing coming down. Sometimes these stones can be very subtle, especially if they're mixed with other pathologies. So we're going to be looking for those subtle shadows that may be occurring. Biliary tree itself. So we have the intrahepatic biliary tree, right? So that's coming from the hepatocytes, getting kind of bigger tree branches. Then we have that right and left hepatic duct, becoming the
Common hepatic tract.
common hepatic duct, and then it goes to the cystic duct and back, and then it becomes the common bile duct. And where does that terminate? The
Duodenum.
posterior aspect of the head of the pancreas, and then it ties in with which duct? Which is also known as
Wirsung.
duct of Wirsung. Sounds like a magician or Saint-Germain. But anyway, and then that's going to terminate in the duodenum, and what is kind of that area called?
OD. Sphincter.
The sphincter is called sphincter of Oddi, but that area, the ampulla of Vater, yep, Darth Vater. So we're going to look at our biliary tree for dilation, so intrahepatic or extrahepatic. Obstruction, contents, wall thickness. We'll talk about wall thickness. It's not something we usually observe, but there's one pathology associated with it that we'll talk about here. All right, so when you're scanning the liver, you're going to kind of notice the gallbladder going by. You haven't really looked at it yet because you're focusing on the liver, but we're going to kind of pay attention to where he ends up. We're going to evaluate from the neck to the fundus. Sometimes these are kind of U-shaped or horseshoe-shaped, so we might have to take some images from neck to body and then additional images from body to fundus. So don't be afraid to add a few images in there just to make sure that we're clearing everything out. Pericholecystic fluid, what is that? So what's peri?
Around.
What's chole?
Gallbladder.
Like biliary. And cystic. So around the gallbladder, cystic fluid. So near the gallbladder. So we're going to see a little bit of smidge of fluid around there. This is different than the ascites that takes up the entire abdomen or that Morrison's pouch. But sometimes we can have just a little bit of trace fluid. Use caution, because the more you look at it, the more pressure you put, it squirts away. And you're like, no, really, I saw it. Please believe me, I saw it. It was there. So make sure in your images, if you're seeing it, you're not using a lot of pressure to document it, and then you can start using pressure to evaluate the gallbladder.
So is it a good or bad thing?
It's usually associated with pathologies. So if we see cholecystitis or some of the other biliary problems we're going to talk about, you may see pericholecystic fluid.
So when you see the pericystic or bladder fluid, you don't want to push on it, otherwise.
No, I'll put a color box just to show that it's there. Like, oh, here's fluid, and then I'll start my evaluation because it likes to, there's not much of it, it's just kind of a smidge, so then it will push away as we start moving around. Okay, so how do we find this gallbladder? What's it attached to?
Liver.
Pardon me?
Liver.
It's attached, how is it attached to the liver?
The fundus look anteriorly. It's
But there's a very specific connection. Remember, like, some housewife that's really hot to teenage kids. The milk, the main lobar fissure. You got it. And so it's going to connect, the neck of the gallbladder is going to connect to the right portal vein through that main lobar fissure. So we can always kind of go, and we'll talk about this in lab when we scan it. We can always find that main portal vein, cruise over to the right and look around, or we can go in SAD and just follow that main portal vein to the right portal vein and look around. And we'll follow that up in lab. But everything's kind of touching. So biliary. So we're going to notice those intrahepatic ducts while we're scanning. We'll talk about some of those pathologies today. Intrahepatic ductal dilatation, IHDD. Very exciting stuff. So these further in our PowerPoint. And then we want to follow up from the porta hepatis all the way to the pancreas. So it's not enough that we're seeing just a smidge of that common bile duct. Keeping in mind, you guys are flight sonographers. You're going to see just a smidge of it for now. But ideally, we want to evaluate from the common hepatic all the way to that distal pancreatic head. And then CBD, how do we find it? Where does this thing live? Who's his neighbor? hepatic artery, and he's pretty small, so who's the big guy in this building? Portal vein. So we're gonna look around that portal vein. Okay, so here's our NPO gallbladder. So we've got this anechoic lumen, we've got this nice clean thin wall. Now when we do our measurement, we're gonna measure this anterior wall. Why do we have enhancement? What is going on here that it's so bright?
Because of liquid in the gallbladder?
Because liquid doesn't reflect, right? So our beam is preserved, and that's called what? Enhancement or through transmission. Two words for the same thing. So we have less attenuation, less loss of beam in that structure, so our beam is kind of preserved. Okay, so here's our NPO gallbladder, nice and sluggy looking, and now you can start to see our wall gets a little bit thicker here. So we still have that hyperechoic area, but then we also have this further layer that's a little bit thicker as this starts to contract. Do we know if it's diseased or NPO? We don't know, we're gonna have to ask our question. Oh my, look at this bad boy, very contracted. So this guy will eventually get so contracted that we can't find him. So when you guys are in lab with each other, kind of practice, like, eat something fatty and then scan after an hour, continue eating, or just wait and see how far this thing can go away. Because sometimes you just can't find it at all. You're like, I have no idea. The patient ate 3 Whoppers on the way to the ER, so I have no idea what this thing's doing. Okay, so here's a diseased gallbladder. So this is what we call chronic cholecystitis. We'll get into in a second now. So we've got our gallstone here. So how would we describe this? Okay, what else? So echogenic, shadowing foci within the lumen of the gallbladder. And one thing we want to determine, we'll talk about this in a minute, is mobility. Does this thing move or is it stuck? And then you can see just how thick our walls are. How do I know that's a stone? How do I prove that?
Shadowing?
The shadowing. Here's the hydropic gallbladder. So can anybody see why this is hydropic? See shadowing. So in the neck of the gallbladder, we have a significantly blocked neck with a echogenic shadowing foci, and then we've got a little bit of wall abnormality here, but you can see just how plump this looks. So our slug is kind of inflated a little bit.
So it's stone right there, or?
Yep, there's a stone right in the neck. So echogenic shadowing foci.
Now, what is it on the top?
So we'll talk about this. It's cholecystitis, so it's an inflammation of the gallbladder wall, and we'll talk about that as a pathology here in a second. Very common clinical indications with any kind of gallbladder pathologies. Right upper quadrant pain radiating to the right shoulder, and that might be the posterior aspect of the right shoulder. Postprandial pain. What is postprandial pain?
After eating?
Pain after eating. You got it. And when you're talking to your patients, you're not going to say, hey, you got any postprandial pain? Some of that postprandial pain. You're going to say, do you have pain after eating? But when you're speaking to the radiologist or when you're writing on your worksheet, you're going to say postprandial pain. Sonographic Murphy sign, we talked a little bit about this. What was this? Yeah, when they want to punch you in the face versus, that doesn't feel good. Okay.
I have a question about that. So, is that like pain when you
She's
push
just right
it,
over the gallbladder.
or is it, do they still have pain when you release it?
So there's something we call rebound tenderness that happens in appendixes. So you put the transducer down, it doesn't hurt, and then you pull it off, and it does hurt. So it's called rebound tenderness. This doesn't have rebound tenderness, it's just very tender when you apply pressure. And there's a clinical and a sonographic, so they may get them in the ER and poke them a little bit. We might do the exam because they had clinical positive Murphy sign. And they can be tender and not have the Murphy sign. So they can still be tender and just be like, ow, that hurts, but if they're like trying to crawl away from you and punch you in the face, then you know. Yeah, go ahead.
So, if you're like asking a patient like after they're like, if they have pain after eating, they're like, why? Why are you asking me that? Because sometimes
Just
like,
say, oh, it's, something that's oftentimes associated with the reason your exam was ordered.
okay.
Like, you just kind of bullshit right there. So if they're for right upper quadrant pain, that might be part of your history questions. What makes this better or worse? Oh, it's worse after I eat. It's better when I sit up. So it might just be part of your questions.
Okay.
Okay, nausea and vomiting, jaundice, increase in bilirubin. Why would that be? Obstruction, better word. Obstruction, right? We're fancy here. We're fancy. And then this thing called Courvoisier's sign. And this is very specific to the panc and the biliary tree. So what will happen is you'll have an enlarged gallbladder and they'll have painless jaundice. So So it's not because the biliary tree itself is obstructed, it's obstructed in the head of the pancreas, and it's most commonly associated with a pancreatic head mass, which is adenocarcinoma, pancreatic adenocarcinoma. So they'll have painless jaundice, they're like yellow looking, they're like, I feel fine, and you're like, your gallbladder's like bulging out of yourself. You're like, no, I feel great. And then you look at the head of the pancreas and you see a big mass obstruction. So that's that specific cause here. I'm kind of out. I'm thinking I'm getting old. I have Kleenex at every coat I own. Every time I wash a pair of pants, it's like Kleenex everywhere. Okay, so our first pathology, sludge. Not really that big of a deal. Something you're going to run into fairly commonly. And typically these patients are going to be asymptomatic. It's going to be something you find. If we have prolonged fasting, so those bile salts kind of just sit in that gallbladder and they just start to solidify. This can either be kind of an entire layer of sludge, or we can have what we call sludge balls. We'll look at those here in a few minutes. So this can occupy the entire lumen. So I can't get my lumen anechoic, or we can have that fluid level where we have like a little bit of sludge at the bottom and regular bile at the top. If I change my patient's position, this is going to roll with them. It's just kind of loose in there. One thing to take note of, because this is a little bit brighter, it's not a bright level gray, it can hide stones. So we want to make sure we're looking for any shadowing that's coming out of the gallbladder, and we may not see the echogenic foci portion of the stone, but we may see the shadowing associated with it.
I have a question about that fasting, how the prolonged fasting can increase or solidify bile salts. So is that like a negative thing? Is that how can it become problematic due to fasting?
Some of these patients over time will report right upper quadrant pain, but it's pretty much an incidental finding for us.
Oh.
It isn't something patients are often like, so what will happen is prolonged fasting. This isn't like you guys having to be NPO in the morning. This is going to be like people who maybe for religious reasons do prolonged fasting, or they're stuck on a desert island, or whatever, for whatever reason, some of those diets that they have where you don't eat for 3 days. So the gallbladder basically is housing all that bile and those cholesterol salts and all that kind of stuff, and so it doesn't have anywhere to go, so it's kind of like clotting. Basically just clots. Sometimes it can leave the gallbladder if it's a thin enough viscosity, if it's a low viscosity. Other times it will just sit in there and live there forever.
Okay.
So it's not something that changes once they
No, it kind of sticks, and they may, if it's very low viscosity, it may actually go out with the bile, but typically it's like a big thickened area, so it kind of just stays there. Kind of like mud, think of it like mud. Okay, so we're going to see some low-level echoes with mobility. We're going to have that fluid level, and then this can be just an entire gallbladder full of this, or it can be just a very small layer at the bottom. And the smaller the volume, the harder it is to see, because you're like, is this just the bottom of the gallbladder wall? So you go to the patients and you realize it was sludge. So again, that 2 planes to look at the gallbladder. We want to prove that it moves with position change, and then we want to prove there's things called sludge balls that don't shadow. They look a lot like gallstones, but they won't shadow. So we want to prove that there is no shadow for these. So let's look at some of these bad boys. So here we are in sagittal. So here's our typical bile. So here's our whole gallbladder right in here. And then we have this kind of sludge accumulation in the dependent portion. As we roll this patient, that sludge is going to continue to roll to that more dependent portion. Here's another little accumulation in the fundal portion, the body of fundus.
Is it something also in the upper part of it?
No, I suspect this is actually in the liver. This looks like maybe some focal fatty.
No, I mean more to the right, like the white stuff.
My side? Your side?
No,
this side?
Anterior fundus.
Anterior fundus?
Yeah,
I think this is just, you know how you guys can't really get your aortas to fill in? That reverberation artifact? Because this is always going to be in a dependent portion. It's never going to like float to the top. I think that's just boring. Let me show you what this is like. See, it's just kind of hazy. Okay, sludge balls! Yay, sludge balls! So you can see we have these little kind of focal balls of sludge. So these will also roll to the dependent portion. And the key that these are not gallstones is they don't shadow. No shadow. So here we have sludge and stones. So we've got, here's our gallbladder lumen right in here. We've got a little bit of bile, kind of a crescent of bile up top. Here's our sludge in here, and we've got these stones kind of hiding in here. And we can kind of see a little bit of subtle shadowing throughout.
sometimes we do have inflamed walls with the sludge. Sometimes it could be good walls.
Typically, if you're gonna have inflammation of the walls with sludge, it's because there's also stones present.
Ah.
Usually you're gonna have a normal wall thickness with sludge, it's just an accumulation, it doesn't
Okay.
really irritate the walls. So
Okay.
if we have wall irritation, typically we're gonna have stones.
Okay, got it. Thank you.
Okay, cholecystitis, let's spell this one out. Chole, gallbladder, cystitis, infection. So basically an inflammation of the gallbladder wall. And commonly, this is gonna be from stones, and we have acute, so short-term, chronic, long-term, acalculous, which is a very specific type, and we'll talk about him. So there's no stones associated, it just happens. And then this can proceed to, the acute can proceed to emphysematous, and we get like gas in there, and then gangrenous, where the skin is necrotic and rotting and perforating.
Which one was commonly from stones?
Everybody except this one,
Okay.
the acalculous. Okay, so most commonly caused by stone in the cystic duct. Common in females. We females get biliary problems more than males. Males get the triple A's and the prostate problems. We get biliary stuff. So this acute can, again, so we can get emphysematous, so that's where we have the gas producing pus in there, so we might get some gas cloud in there. Gangrenous, so the whole thing's rotten, or we can actually rupture or perforate our gallbladders. Not ours, totally not ours. So females over the males, that positive mercury sign is going to be a big deal. Fever, why do we have fever?
Inflammation.
With infection, we're inflamed, think about it. Increased white blood cells, abnormal LFTs, and serum amyloid. And then we're going to have a thickened gallbladder wall, although this may be variable. You may have an area of thickened wall and an area of normal wall. So I'll measure the normal wall, and I'll measure the thickened wall, and say variable wall thickness from 2 to 5 millimeters. Just kind of give a range for them. So wall edema or hyperemia, and so these are like where our wall is thick and there's kind of hypoechoic layers in there. We want to put our color Doppler on, is this wall edema? Is it fluid accumulating in this gallbladder wall, or is it hyperemia, where we actually have increased blood flow to the wall? So we want to be able to distinguish one from the other. So we're going to use our color Doppler. And a lot of the pathologies we're going to talk about today are going to kind of relate to this wall edema thing. So making sure we have wall edema or hyperemia. So high probability of stones. Sometimes we can have this, and there's a little tiny stone that then became out of the gallbladder lumen into the neck and into the ducts. So when we have cholecystitis, I'm going to peek around the biliary tree just to see if anybody snuck out. Like, who's sneaking out? Okay, yes, okay, I see you, yes. Hydropic, if we get obstructed, so we're going to look downstream. So if I have an enlarged gallbladder, biliary tree might be dilated towards that liver, so we're going to look downstream to see where that obstruction is. So evaluate the wall. And then intra and extra hepatic ductal dilatation, looking for that pericholecystic fluid, and then we're going to poke our patients and see how mad they get. You mad? You mad? Come at me, bro? See if we have a positive purpose. All right, so here we go. So this has also some sludge associated with it. So we've got some sludge in here, our normal lumen, and you can kind of see how thick this wall is, and then there's kind of hyperechoic striations. Now to know for sure edema versus hyperemia, what am I going to do? Put my color on. Is this going to be a high or low velocity?
Low.
Pretty low, right? It's not like an artery. It's just kind of hanging out in front. Here's another one. So you can see we've got kind of the striations within the wall. So here's our wall thickness right in here. And the area of your thickest wall may not show your stones. So if you have stones and a thick wall, make sure you're taking multiple images of that. And there's also what we do, they're called city clips, which, who was it that took a bunch of them by accident? Yeah, Tima. So Tima was like, capture, like all of her images were like, here's a mini movie. She's like, how do I print these? I'm like, well, you can't really do that. But, so you also do these little mini movies through the radiologist to kind of see, like, okay, them out of the gallbladder, in the gallbladder, and back out, so you can see what you're taking in live time. All right, oh, this is one here. So this is pericholecystic fluid. You guys see this, like, this little smidgy of fluid in here? So if you squish him too hard, he's going to go away. But there's that pericholecystic fluid.
How we will differentiate its peritystic fluid or its rupture of our gallbladder?
Ruptured gallbladders look horrifying. And we'll see them. They don't just rupture. It's not like you have it and they're like, ooh, I cracked open like an egg. The walls are going to be really thick. They'll start to kind of fenestrate into themselves. And I'll show you some, it looks horrifying. We'll get to that in just a few minutes.
Mm-hmm.
I think Rain showed a picture.
Yeah. But it looks like this.
Okay, now we're good.
The wall was different, but fluid was like this.
Yeah.
Vascularity does help.
Mm-hmm.
Okay. So any questions on, that's acute cholecystitis, we're gonna get into its complications here in a few minutes.
I have a question. If patient has such severe pain he couldn't tolerate our exam,
Too bad.
can we ask somebody to give him
Don't
some?
ask her. So those patients are typically gonna be your ER patients.
Uh-huh.
They're not like outpatients who are coming in, but yeah, you could just say to the nurse, like, hey, my patient's in a lot of pain, can you give me something for him?
Okay, got it. Mm-hmm. Thank you.
Knock them out, they don't have the time. Okay, so chronic cholecystitis. Okay, so we've had acute cholecystitis, we've had these gallbladder attacks, we might have some stones in there, and oh gosh, I feel terrible, didn't come to the ER, maybe it subsides after a few days, and this has happened recurrently. So we've had this happen multiple times, so this is very common. So common is chronic cholecystitis. So basically, this inflammation results in fibrous changes, kind of scar tissue within that wall of the gallbladder. So it can never really get large, and it can't really do a very good job of filling with bile. So it stays somewhat contracted all the time. So also it can be associated with what we call with stones. So wall, echo, shadow. So we see the wall of the gallbladder, we see the echo either from one large stone or an accumulation of multiple stones, and then we just see shadowing. So we aren't able to look in the lumen of the gallbladder very well because of the shadowing. So wall, echo, shadowing. We're going to see a couple other pathologies that mimic this, and we'll compare them to the other pathologies later, but these can be confused with other pathologies such as porcelain gallbladder or emphysematitis.
What is the difference between cholecystitis and sludge?
Cholecystitis is an inflammation of the wall, and then sludge is just that accumulation within the lumen.
But for the sludge, the wall could be thick too, you know?
That one did, but not all of them. So like this is a normal looking wall with sludge. This is pretty normal looking wall. This guy's not so hot looking, but he also got stones in it as well. Does that help you?
Yeah.
Okay, so wall echo shadow, we're gonna talk about that a little bit more in a minute. Females more than males, okay, got it. Right upper quadrant pain, these are gonna be less tender than our acute cholecystitis, and it can be kind of transient. Like, yeah, it hurts a little bit every now and then, but it's not like the acute when that gallbladder compresses on that stone and the stone's irritating the wall and then the wall gets inflamed. So those are the acute's much more painful, much more focally painful. So abnormal LFTs, serum amylase may be increased. Notice that we don't have the increase of white blood cells in this liver. Our infection has passed, it's done, it's just fibrous changes, scar tissue is happening in the wall of the gallbladder. Okay, contracted gallbladder. So again, how MPO are you? And my patient's like, I haven't eaten for 24 hours. And I'm going to note that on the worksheet. Contracted gallbladder despite being NPO. So we know like, hey, this is a problem. It's not just your food. Wall edema or hyperemia, that wall echo shadow sign. So that might be one large stone in there, or it could be what we call a packed bag, where it's so full of stones that we just can't see the lumen of the gallbladder. Edema, hyperemia, ducts for obstruction, pericholecystic fluid, and then again, is our patient NPO? Is this contracted because of NPO, or are they lying to us that they're NPO?
I have a question about the stones. I always figured that the stones are sitting in the lumen because when you move the patient, the stones can move.
Stones are.
And so immobile stones are within the wall itself.
Not within the wall, within the lumen, but they just aren't going anywhere. So you can have two kinds. So we have that packed bag where it's just like a bag of marbles where nothing really moves in there. Or you can have one that's actually like lodged in the neck or lodged in the fundus.
Okay, so it's not that the stones would develop within the walls, in the layers of the wall.
No, they're within the lumen.
Okay.
So they're comprised of like those bile salts.
Mm-hmm.
So that's all contained within the lumen.
Okay.
There are some wall pathologies, but not stones.
Okay.
Okay, so here is a chronic cholecystitis. Yucky, yucky. He's actually the first here in a second. So here's another one. So here's our gallbladder, looking very contracted. Here's the lumen. What is going on with this guy? Stone. And then we've got this thickening wall. We've got that hyperemia versus edema in the wall.
So what's the wall, why isn't that called a cystic,
It's cholecystitis, it's just chronic.
okay.
Yeah, it's just long term. And there's actually two pathologies here. So we have the chronic cholecystitis, the dead giveaway is that contracted gallbladder. And then we also have what we call cholelithiasis or the stones. And usually cholelithiasis and cholecystitis go hand in hand. And there's one time that they don't, which we'll talk about, which is that acalculus. Okay, so here's that west side. So we're able to see the wall of the gallbladder, a little smidge of lumen over here. Sometimes we don't get to see that. Here's the echo of the stones, or multiple stones, and then shadow, so the west side. So wall, echo, shadow, our west side.
And how would you distinguish if it's acute or chronic, just by the picture?
In this case, you would just say west side noted, and that's up to the radiologist to determine. Because we can't really even see, like, we can see the anterior wall, but we can't really see the posterior wall or evaluate any kind of renal contents. So we would just say west side noted with the gallbladder.
So west side is basically like where you basically can't see the gallbladder, or what's the
With this particular pathology, there's other times we can't see the gallbladder. But in this particular, so we see wall, then the echo of the stone or the multiple stones, and then just shadow.
That's the west side node?
That's the west side. Use the west side. Okay. Acalculous cholecystitis. So this is that cholecystitis that's not associated with stones. And this is a very specific type of cholecystitis. So we have inflammation, but it's caused because of decreased blood flow to the gallbladder through the cystic artery. Our cystic artery is compromised. So when the artery is compromised, those tissues are being perfused, so they kind of start to necrose and rot away. Like they're like, we don't have enough blood supplies, we're gross. And we may have like trauma, burn victim, postoperative patients, and we may just having a mass compressing on that cystic duct, which is preventing that blood flow in and out. Okay, so recent trauma, positive mercury sign, abnormal LPs, increased serum amylase. And it's going to look very similar to acute cholecystitis, but there's no stones. It's acalculous. There's no stones associated with it. In order to ensure that it's acalculous, we also want to look downstream to make sure there wasn't a stone that was leaked out and is now in the biliary ducts, and so it was calculus and now it's not. So we want to make sure we're evaluating all of those ducts. Same thing that we talked about with everything else: obstruction, edema, hyperemia, mercury sign.
And then just to confirm, you compared that having no stones to, what was the name of the one with the stones that you compared it to?
Cholelithiasis.
Cholelithiasis.
Oh, wait, no, I'm sorry. Cholelithiasis is the stones. So there's cholecystitis,
Okay.
acute, chronic, gangrenous, emphyematis. Those are the big four.
Okay.
And then there is acalculus, which is cholecystitis. All of these are associated with stones. This one is not. It's
Okay.
associated with trauma, some sort of lack of perfusion to the cystic artery.
Okay.
So that's the only thing that would differentiate.
Yeah, and that's why we want to look downstream, like, was there a stone that just leaked out, or is this truly acalculous? And most of these patients are going to have, like, history of trauma, burn victim, there's maybe a mass compressing on that cystic duct, cystic artery area. Okay, so this doesn't look like much. It's kind of a sludge-filled gallbladder, but there's no stones in it, and we still have that thickened wall. So ignore the sludge. We don't care about the sludge, but we are looking at the thickened wall, and there's no stones associated with this. Here's another one. So no stones, but we're seeing this thickened gallbladder wall. So how do we know if this is edema or hyperemia? Put your color on it. You got it. Okay, so this is a complication of acute cholecystitis, and it's rare, and it's emphyematic. So this is where we get those gas-producing bacteria, and this can actually, the bacterial infection can go then down the cystic duct, into the biliary ducts, into the livers. You might have what's called pneumobilia, which is gas in the biliary system of the liver. So we may have pneumobilia. About 50% of these patients are diabetic, about 50% have stones, and then look for that gas show. So, diabetic, history of stones, leukocytosis, again, because we have an infection going on. So this is going to look very similar to that web sign, but instead of having that very anechoic, black-looking shadow that we see with stones, it's going to be more of a fuzzy, hazy gas shadow. Does that make sense? And then pneumobilia. So we're going to evaluate, is there any gas in the biliary tree itself? So pneumo, gas, bilia, biliary. So is there gas in the biliary tree? So So not just in the gallbladder itself, but have these bacteria crept up into the liver or maybe down the extrahepatic ducts and started producing gas shadow. So here we have very similar to our wall-like shadow, right? Except our shadow is now hazy. It's a gas shadow versus having that stone shadow. We still have the wall. The echogenicity associated with it is the reflection of our beam off of that gas. So you guys have seen bowel go by, right? You're like, what am I looking at? It's just really bright here as I'm trying to do the mid-aorta. It's very bright and kind of hazy. That's what we're seeing. So it's gas shadow. So different than our wall-like shadow.
How do we know if it's good shadow or?
Because your little eyes will learn. So the stone shadows can be very, very dark. So our beam is not able to penetrate through. It's just all reflecting back. Whereas gas shadow, it diffuses our beam. And so we have a little bit of beam returning, so it's more like a dark gray versus an absolute black.
This is that?
This is gas shadow. Yep.
Yeah,
And
but
then
how
you'll
do you
compare
know
that-
if it's gas shadow from the gallbladder or just regular from my stomach or whatever?
Because you just look for the MLF and you'll try to find the gallbladder neck, and if there's a big shadow there, you know what's going on. Landmarks, right? You'll get to know, and I know you guys are like, I have no idea what I'm looking at these days. This is amazing. You guys will get to learn what normal anatomy looks like, and you'll be able to recognize that little Easter. So, don't worry. Okay. Here's another one. So we're not even really able to determine the wall very well. We're just seeing a small section of it. And we have that echogenicity from the gas, but then we have that gray shadow. It's not a black shadow. It's more of a hazy gas shadow. Now this is air in the biliary tree. So this is pneumobilia. And so we're in the liver, and you see all these little bright areas? That's where the gas is, our beam is reflecting off of that gas. These are looking at bright pockets. And this is the only time anything will ever look like this in the liver for pneumobilia. You'll never see gas shadowing in the liver aside from pneumobilia.
And pneumobilia is due to that bacterial traveling
It's
bacteria.
traveling up the biliary tree, it's gas producing, so it's like, I'm gonna hang out in the left liver lobe and make a bunch of pus and gas, and then it reflects, our beam reflects significantly off of it. We may have some of that gray kind of, this isn't the best image for it, but the kind of the gray hazy shadowing as well.
Okay.
Wait, so the emphysematous cholestasis, is that also like the same thing or?
Emphysematous?
Yeah.
Yeah, this is associated with emphysematous.
Oh,
So emphysematous is when it's in the gallbladder, but then as these things creep out into the biliary ducts and they get in the liver, then we call it pneumobilia.
Okay.
It's not just in the gallbladder anymore, it's in the biliary tree. Okay, gangrenous, this is the grody one. Okay, so complication, and so this is a surgical emergency. Most of these patients are going to have gallstones. But what happens is we have acute cholecystitis. We've got that infection, inflammation in the wall, and it goes untreated, and then the wall starts to necrose. And so it's basically rotting. So gangrenous, right? You know, remember gangrene, old people get gangrene, their legs fall off, or their toes get bitten off by their dogs or whatever. And so in this case, the wall starts to perforate. So you can actually have rupture of the gallbladder. So this is a surgical emergency. We need to get this out of there. So history of cholecystitis. It says in your book may have right upper quadrant pain. I guarantee you these patients are going to have right upper quadrant pain. It may not be as severe as our positive burpees, but this thing is rotting inside of them. So you know it's going to be painful. So we might see thick irregular wall. Now, echogenic material in the gallbladder lumen. Now, this is part of the wall that's necrosing. So the wall is starting to kind of invaginate. Pieces of it are starting to fall off and layer within the lumen of the gallbladder. So it's not sludge. It's not like sludgy looking. And it's not going to be gravity dependent because this is just kind of hanging off. The wall is like starting to deteriorate. Think of it almost like a dissecting aneurysm. And you know how those walls are starting to separate from the different layers are starting to separate. It's kind of like that. So wall integrity, so we want to look all around that gallbladder. We want to make sure that if there's fairly polycystic fluid, chances are it's going to be bile that's leaking out of the gallbladder. We just want to make sure that what we're dealing with. And then because we're dealing with a potential, necrotic tissue, things might bleed, so we may have an adjacent hematoma. Do you remember hematomas and all that business? So this is our gallbladder right in here. We've got a little bit of fluid around this. I don't know if this is in ascites patients as well. But we're starting to see like our wall is starting to fall apart. So this should be in the fundus, and it's kind of falling down. Here's another one. So you can see this is our wall, and it's starting to kind of necrose and fall apart. So this is actually a portion of the wall that should be kind of glued back up into that anterior. Here's another one. So this is perforated. So the gallbladder itself is this section, and then this is bile that's leaked out. You can see that we have a deviation in the wall. We've got an opening in that wall. So here's our wall, looking kind of thick and kind of falling apart. Hole in the wall, and this is where the bile starts to leak out into the adjacent area. And what does bile do? What does bile do? What does it do specifically?
Digest fat,
Digest fat. So what are surrounding all of our organs?
membranes.
Fat.
Oh, fat too.
Yeah, so this is going to start digesting.
Mhm.
Yeah, pleasant, right? Uh-huh. Yeah, yeah. Okay, so here's another perforated gallbladder. This one happens to have stones in it as well, and you can see our wall is not continuous. So we're leaking bile out into the areas surrounding it. Who's ready for lunch?
So the whole thing is gallbladder, or where is the
No,
gallbladder?
this I don't know what this is. This might be like a hepatic cyst. Ignore this, it's this right here. So here's our gallbladder, stones in the gallbladder, normal lumen, perforation, bile leaking out. Looks like a stone flew out too.
How do you tell the difference between this and like the septation to like the little tap?
Because these won't, because this, your demographics are going to be much worse, right? Your patients are going to have much worse feelings or whatever. The Frisian caps are the normal looking, just have a little fold in them. Nothing about this is normal. Pericholecystic fluid with that bile that's leaking out. And even with the folds, you still have an outline of the gallbladder. In this case, you're like, here's the contour of the gallbladder, there's a big hole in it. You know what I mean? You'll notice that there's like a missing section. Okay, questions on our cholecystitises. So we had acute, going to be the one you most commonly run into. Chronic, more common they say in the book, but I usually run into acute because I work in the ER. And then we had the acalculus, which is usually due to trauma, post-operative, burn victim stuff, so some compromise to that cystic artery. Then we had emphysematitis, gas producing, and then we had gangrenous, where that thing is just basically rotting in there and perforating. So those are big types of cholecystitis. Any questions on those?
If you did run into that, like, busy sites in that program.
Oh yeah, I'd call the ER and be like, this patient needs to go straight into the ER. No. So I'd call the radiologist and say, hey, this is what's going on. Do you want me to call the ER? Do you want to call the ER? And 9 times out of 10, like, you call the ER. So I call the ER and I say, hey, preliminary results, we have gangrenous, cholecystitis. We're going to bring the patient back to you, or we just take them straight down to Walters or so. What do you want me to do?
Do you stop the exam or do you finish it?
I would minimize what I needed to. So like if I'm doing a right upper quadrant and it's for the gallbladder stuff, I would take, because this is gonna happen after the liver images, but I see this go by, I'm taking my liver measurement, maybe like one sag, one transverse, looking at the gallbladder, and then so it's gonna be a minimum exam. So I still have to look at things, but I'm not gonna do my portal vein assessment. I'm not gonna be like, oh, maybe you should do your good clavicular, oh, Richard Morris pouch, and I'm like, this is a nightmare. And I had a similar case. It was an ectopic pregnancy, and she had an ectopic, and it was really horrible. It was hemorrhaging. It was a live ectopic. She was totally hemorrhaging, and I was just like, I'm not gonna go get the other ovary. I'm not gonna get waveforms on the other ovary. I'm just like done. And so then you put exam limited due to findings. So like the idea, I couldn't continue this because this was not. Oh, that scrotal I had with the big pseudoaneurysm that was draining into his scrotum, and I'm in the ER, and I'm like. They're like, do a scrotal ultrasound. His scrotum's huge. He's in shock. He's like getting sternal rubs from Shea. Like, hey, and so I popped my head out the door. I was like, you need to call a vascular surgeon. He's got a pseudoaneurysm. He's draining into his scrotum. They're like, really? I'm like, yeah, really. So then they came in and like, look, here it is. Vascular surgeon comes in like 5 minutes later. I'm like, here it is. And so then my exam was discontinued due to findings. So like that's bigger than like, how big is your left testicle? No one cares about that. Okay. having stones, cholelithiasis.
Mhm.
Chole, gallbladder, litho, or life, lift, whatever, stones, a cyst. I don't know what happens. I don't know what that part is. Okay, so this is going to be the most common one you see. So stones are often associated with our cholecystitis, but you can have stones that just rattle around there in there for years and nobody even knows. We might even find some on you guys. We've had that happen in past years. You bring your neighbor in, you bring your mom, dad in, and you're like, hey, you got gallstones. They have no idea. The big ones are better because they just kind of rattle around in there and don't cause problems. The little ones are the ones that sneak out into the ducts and cause the obstruction. Those are the worst ones. So the 5 F's, that's us, ladies. Okay. Fair, white people. I'm 40. I'm a female. I'm not really fat, but I'm doing the almost chocolate milk binge. I don't know. And then fertile, so premenopausal. So those are our 5 F's. So those are big demographics for people who get stones. Granted, other people can get stones, but these are just our highest ones. So also pregnancy is very common. You can actually have fetuses in development obstetrically that have gallstones, which is kind of interesting. Diabetic, OBCs. What are OBCs? I take, it's like candy, so I don't have babies.
Birth control.
Oral birth control. Yeah, oral birth control. Yeah. Significant weight loss, so significant metabolic changes in your patient. And if we don't have any obstruction, or we don't have acute cholecystitis associated with this, our patients may never know, so they can be totally asymptomatic. If we do have some pain, it might be that after we eat and the gallbladder contracts and it's contracting on those stones or stone, then the gallbladder might be a little bit irritated, but we may not fall under the continuum of acute cholecystitis. And then of course epigastric, it's in that neighborhood, nausea and vomiting. So if we have obstruction, we might see increased bilirubin, sometimes third, and like temporarily, and then abnormal LFT. Echogenic, shadowy masses. And when we get these in the ducts, we call it choledocholithiasis. So gallbladder duct stones. So these things can sneak out. Sometimes they can form in the ducts. We'll talk about that in a few minutes with its own pathology. But most of the time, they're going to sneak out of the gallbladder. So if we have a large, what we call large stone or packed bag, you might see that wet sign. And then what we're going to see with cholelithiasis, if we see obstruction, we're going to put color Doppler on. So we have that portal triad. So there should be a portal vein right next to a biliary duct. So if I have biliary duct dilation, I put color on, one of those is going to light up, and one of them isn't. And so that's called our shotgun or our double barrel sign. And that can happen extrahepatically, like at the main portal vein towards the peg, or it can happen intrahepatically. And as we get cruising down the road in this lecture, we'll see a couple of those for a while. Mobility, very important. So are these things mobile? Send them home, we don't care. Are they immobile? We care. It's going to cause biliary obstruction. And I've had to do crazy things with patients to try to get these. You can have them like jump up and down. If it's stuck in the neck, you can have them jump up and down. You might have them cough. And I've had to do it before, and I felt very pervy about this. So the patient is leaning over the table like this. I'm trying to get this stone and stuff. And I'm like this, like wrapped around him, like, no, it's fine, it's fine. So sometimes they get a little squirrely with the patients. And then again, because this is so commonly associated with cholecystitis, just making sure that our wall integrity is correct or well. Here we go. So we have our normal gallbladder wall, no cholecystitis associated with this. We've got 2 shadowing echogenic foci in the lumen of the gallbladder. Do you think these are mobile or immobile?
Mobile.
Mobile. And how would we prove it? We're just going to do a position change. You got it.
So the difference between this one and the other one with stones is that these walls are normal?
So the other one is the walls that were abnormal due to stones. And this is just the pathology of the stones. So before we saw the wall abnormality with the stones, we were seeing 2 pathologies. And this is the second one we're looking at. So cholecystitis is just the wall abnormality. And it's oftentimes associated with cholelithiasis. And now we're just picking out cholelithiasis. Good liar. Okay, all right. Okay, so here we have that chronic cholecystitis with that stone again. Do we think this guy's mobile or immobile? Possibly immobile, huh? Look how contracted our gallbladder is on there. So we want to switch our patient's position. Oh, look at these little monsters. So these are the ones that like to trickle out of the cystic duct into the common bile duct, cause obstruction somewhere, cause pain, biliary dilation, and then they laugh about it as the surgeon has to go in and review. Look at the trouble I have. Okay, so this is that cholelithiasis with the west side. Ignore this, we don't care about this. But again, we're seeing that wall, it's that echo, and then that shadow. So this patient's wall is normal, but he's got that west side. So cholelithiasis, as we saw with our chronic cholecystitis, the west side, because of cholelithiasis. So they go hand in hand. Okay, so one step further. So these stones we talked about just being in the gallbladder, we talked about them, and now we're like looking at them as they creep out into the ducts. So they can either begin their life in the ducts, they can get formed in the ducts, or they can creep out from the cystic duct into the common bile duct and get stuck there. More commonly, you're going to see these coming from the gallbladder. So, depending on my area of biliary dilatation, so right now we're kind of talking about mostly extrahepatic. So proximal, liver, distal, pancreas. So proximal is this thing, I have proximal obstruction towards the liver, or I have distal obstruction towards the pancreas. Because that's the way our CB, our biliary tree runs, right? Liver to pancreas. So proximal of the liver, distal of the pancreas. Now, extrahepatic ductal dilatation, so that's going to be our common bile duct, anything outside of the liver. So that common hepatic duct to the cystic duct to the gallbladder itself, the common bile duct to the antherobladder. We can have a little tank duct too, just depending on how the obstruction goes. And then intrahepatic. So this is going to be that common hepatic duct back. So it usually starts at the porta hepatis. So as we're backfilling, it's going to start at that porta hepatis and kind of work its way out into the liver. That's where we're going to see that double barrel shot kind of a cat scratch line. And then we just kind of say, like, how obstructed is this? Is there multiple stones? Is there one? How big are these things? So in history of cholelithiasis, if we're severely obstructed, our patients might get really jaundiced and be very tender and painful. So echogenic shadow foci, but these are going to be within the ducts. Typically, these are immobile. We're causing obstruction. So they kind of creeped out, but it's not like your CVD is so dilated that these things can just kind of move freely. They're causing obstruction of that common bile duct or the intrahepatic ducts. Let's look at some of these. So here we have gallbladder here. A little bit of vein, portal vein, and cross obliquely. Here's our common bile duct. We follow them down. Echogenic shadow and foci obstruction. Shame on it. Shame on it. Here's another one. This is a little bit more difficult to see. We've got some stones right in here. Dilation of that duct. Gallbladder right in here. And this is cholelithiasis within the liver. So these are ones that are formed within the liver. And so you can see they're very small. And they've got that shadow. And so it might be like, what am I looking at? Is this new mobilia? No, because it's not a gas shadow. It's a black shadow. So we know that it's stones. Okay, we're ignoring this. Okay, so in this case, we've got, this is going to be our portal vein kind of obliquely, our IVC obliquely, and here's our common bile duct right here. Very, very dilated. Intrahepatic ductal dilatation. So we're in the liver. So this doesn't look normal. You guys have all scanned the liver a little bit. Like, what is going on with this? So this is going to be, one of these is going to be a portal vein, and one of these is going to be a dilated duct. And I have no idea what GG is. I didn't label on the slide. Who knows what's going on here? So here we have again. So they run parallel. This is a part of that portal triad. So we've got our bile duct in the anterior and our portal vein in that posterior. So if we put color on, one of these will light up and one of them will not. And again, I thought I put pictures of that. Is that crazy? Oh, here we go. Oh, I lied. Oh, here we go. So that's what it will look like. So we have, here's our portal vein in the liver, and then we've got this dilated duct right next to it. I'm running the picture, right? So here we are again in the liver, so we've got some portal venous system, and we have these dilated ducts. So we're intrahepatic ductal dilatation. Oh, actually, it's not like that. Wouldn't be able to do it. Ruining it for you. Spoiler alert. Okay, any questions on ductal dilatation as of now? Okay, so what's it called when these stones are in the gallbladder?
Cholelithiasis.
Cholelithiasis. What is it when they're in the bile tree, the biliary tree? Cholelithiasis. And that's a tough one to spell. It has to be like, but make sure you spell it counts.
which slide are you on? Which slide are you on right now? I've lost my spot.
66.
66. Thank you.
Great question.
Found it. Thank you.
Current slide, okay. Okay, choledochal cysts. So these are kind of, it's misleading to say the word cyst, they're kind of outpouchings from the bile ducts. And they can be congenital, something that you were born with or patients are born with, or we can have a reflux of pancreatic juices, and those pancreatic juices kind of weaken the wall of the bile duct and create like an outpouching. Typically the ones that are pancreatic caused are going to be towards that distal CBD. Anybody that's kind of upstream from that is probably congenital. Are we going to know the difference? No. Do we care? No. So it's just kind of an outpouching. These are going to meet true cyst criteria, and they may or may not communicate with the bile duct. So the outpouching, the congenital ones typically are not going to communicate, but the acquired ones typically are. But who knows? We don't know. Not our job to figure it out. Okay, so females greater than males, and we're going to see these probably oftentimes in infants because of the increased probability of these being congenital. Okay. So there's 4 locations. So we can have a localized dilation, so kind of like what we think of as like a fusiform aneurysm. So there's just dilation of that CBD. Or we can have a diverticulum. So that's going to look more like we got our common bile duct. We have a little bit of a cystic outpouching. So diverticulum. And diverticulum, you've probably heard like bladder diverticulum, just an outpouching on some structure. And we'll get into that with bladders and things later. So diverticulum. Next we can have, so you don't know this yet, we haven't heard about this yet. So here's my duodenum. And like my pancreas is kind of in this neighborhood. And my CBD is coming in here to enter this, goes through the tank into this. And so I might have to have an enlargement of that, of the CBD into the duodenum. So it's kind of like pushing its way through into the duodenum versus just terminating at the ampulla bottom. And then we can also just have diffuse dilation. So the whole thing's just increased in size. What we want to make sure is this large because it's large, or is it large because we have obstruction or some sort of mass compressing on it? We want to be investigative. Like, is this really large? Is this really a problem, or is it just a pathology that's causing this? Okay, so here, little teeny tiny CBD. Here's that cystic area. So here's the outpouching one. So you can see it kind of communicates with the CBD through a small neck. I guess that was all I thought. I guess that's the only one I thought was important. Questions on that? Okay, cholesterolosis. Polyps. So we've all heard of polyps. Basically, these are just going to be kind of little growths that come off of the wall of the gallbladder. And these are very common with cholelithiasis. Polyps are not a big deal. They're going to be anchored. So as we move that patient around versus a sludge ball that will travel around versus a stone that will travel around and have a shadow, these are anchored on the wall. The one thing we do want to make sure of is that where they're anchored to the wall. Okay, yes, we got it. We want to make sure, I don't know, I guess I don't have it. If they're over 1 centimeter, that they're not an actual mass. So they're typically smaller than a centimeter. But as we get larger than that in size, we're like, hey, wait a minute, is this like what we talk about an adenoma, we'll talk about here in a minute. Is this an adenoma? Is it carcinoma? Or is it an actual polyp? So as these things get bigger, we get a little bit more suspicious about them. As they get bigger too, you might see that they have a little root or a feeder stalk of vascularity. Okay, oh yeah, so here you go. The greater than 1 centimeter mass versus polyp. And this is what the specimens look like. So that's why they call it strawberry gallbladder. Yummy, delicious. Okay, so here we are. Look how exciting he is. Chances are when we start doing gallbladders, we'll find at least one of these in class. That's pretty common. Again, fixed position, so as I roll that patient, it's not going to move. It doesn't shadow. So it's not a stone and it's not a sludge ball. It's fixed, so it's a polyp.
What is inside of it?
They're just
What is it made
epithelial
of?
tissue, they're just like any epithelial tissues. Cholesterol deposited in the lamina propria. Very exciting stuff. Sometimes when I actually have to image these, this is one of those times, remember I talked about, sometimes I have to say oblique for the gallbladder. These could be hard to see very clearly unless I'm oblique sometimes. You may have to annotate oblique in order to see the polyp really well. You're going to be oblique on the gallbladder. So. Okay, adenoma. Oh man, it's like I almost heard about these before. That's so weird. What do we know about adenomas?
Vascularity? Or not?
These ones are going to be a little bit different because they're in a lumen.
Okay.
So instead of being in a tissue, but they're made up of glandular tissue, right? Glandular tissue. So these can advance to malignancy, and when they're small, they're usually kind of bright, homogeneous. But as they get larger, they get more inhomogeneous and start to outgrow that blood supply. Remember those adenomas we talked about before, where they get large and they can have central necrosis? So these can kind of do the same. And then if we have an area of gallbladder wall thickening where this attaches, we're gonna say like, is this malignant? We're gonna investigate for malignancy. Okay, here's the fundus, fixed to the wall, non-shadowing. Okay, so here we have, and this is also sludge filled. There's a little bit of sludge in this gallbladder as well. Maybe a little bit of normal bile up here, but here's that adenoma. And you can see he's larger, so he's inhomogeneous. He's starting to outgrow that blood supply. So he's getting a little bit necrotic. Here's one of the fundus as well. So we have kind of normal bile here. We've got this little mass of fundus. That's why it's important to clear out your orders. So sometimes gallbladder funduses like to be covered by bowel gas. So if you're like, there's no problem there. Adenomas love to live in fundus. Okay, adenomyomatosis. Ooh, I'm going to say that 3 times by now. All right, so hyperplastic changes. This is what we saw in class yesterday. I had that little kind of artifact from the anterior wall. It's like a little triangle, They call that ring down or comet tail artifact. And we'll learn about that in physics later. More on that. But these are, I guess these are the epithelial projections. The other ones are cholesterol. So let's see what these bed for. These are typically 900 times out of 900 times going to be incidental. This is something we just see as we're scanning. It's not something patients are going to be symptomatic with. So that comet tail or ring down artifact, this may happen over the entirety of the gallbladder wall, but because of the way we have that anechoic lumen, typically we only see these coming down from the anterior. But they're also happening in the posterior, but they kind of blend in with the Here we go. Look how exciting. Woo-hoo. So they're kind of these little triangular shaped artifacts, either called ring down or comet tail. More on that in physics. They are 2 different artifacts, but they're used interchangeably. Here we go. I think this might be the one we saw the other day. So here we have all these little ring down artifacts. This one's a little bit more prominent. So we have multiple. You kind of see they're like all these little triangular shapes. So do they care about these? No one cares. Okay, porcelain gallbladder. So we talked about that wall shadow sign. We talked about the emphysematous, and here's the third one to confuse you. It's called porcelain gallbladder. And this is where we actually have a calcified wall to the gallbladder. So because it's calcified, these gallbladders are fairly firm, and so they may be like feeling a rock in that patient during his physical exam. And these can advance to malignancy because we really don't want calcified gallbladders. So history of cholecystitis, possible palpable mass if they've had a PT. And you may not see any of the gallbladder, you're just going to see this very echogenic dark shadow area. Now the difference between this and West is we're not even going to be able to see the wall. This is the wall. So we're just going to see echogenic and dark. Whereas the West can see wall, then the echogenic, then the dark. So no wall is going to be visible. And then again, proving West versus porcelain versus emphysematous. So let's see what we got. So here's our porcelain gallbladder. I don't believe that this is the wall, but here we have the entire echogenicity, so we're not seeing any change between the wall and the echo, just echogenicity and then significant shadowing. Same thing. So no real wall. The wall is calcified, so all we're seeing is that calcified wall and just a bunch of shadow. So let's make some comparisons between these 3, because they're very similar. So West. wall, echo, shadow. So kind of three distinct features. Episomatis. Maybe a little bit of wall, but then we have that soft gas shadow. So echogenicity with soft gas shadow. And then lastly, porcelain gallbladder. No wall. The wall is calcified and just a lot of shadow. You'll also be able to determine these as separate based on our patient's skin. Okay, questions on that?
So things about stars are for boards.
Yeah, not for your study guide. Yeah. Okay. And like, dude, honestly, West Side you're gonna run into a lot. Porcelain gallbladder are probably missing once or twice. I mean, the ones that are star are the ones that you're gonna actually like really interact with a lot. Okay, carcinoma. Frequent women over 60. This can mess to the liver and lymph nodes, kind of the surrounding area, as we would expect, or to invade its neighborhood. Because it's late detection, same with our pancreatic adenocarcinoma, it has a really high mortality rate. If you caught it early, the mortality rate is significantly declined. But unfortunately, because it's late detection, by the time we've gotten it, it's already infiltrated the liver, lymph nodes, maybe the spleens affected, things like that. So I encourage you, even when you're out in the world, you're not really supposed to scan yourself. Come on back into open lab, give yourself a once over every now and then, just check things out, doesn't hurt. And it also rapidly progresses.
What are LN stand for?
Lymph nodes.
Oh, okay.
The little canaries in the body. Okay, patients over 60, not a lot of symptoms associated with it. So depending on how this goes, we may have a complex or a heterogeneous mass. We may just have an abnormal wall, very thickened abnormal wall. If we look to that liver, we might see some areas of infiltration. We want to look for any intrahepatic and extrahepatic ductal dilatation and mets. So these things like to spread. So we're going to look for lymph nodes. We're going to look at the spleen. We have splenomegaly. Do we have maybe mets that set up shop in the liver? We talked about that last week. Remember we talked about all the different kind of occurrences that happen with mets in the liver. So what are we dealing with? Yikers. Now, why are we vascular? That's so weird. Who loves blood supply? Who wants to grow and take over the world? Cancers love blood supplies.
Aliens.
So here we have some hepatic infiltration. So this is a stone, and then we've got kind of our cancer up in here, and you can see that it's taken over a portion, the adjacent portion of the liver. Okay, so back to kind of our biliary dilation. So intrahepatic, we shouldn't see these during routine imaging. A diseased liver, we may not be able to see intrahepatic ductal dilatation, say we have a cirrhotic liver or a very fatty liver that we can't penetrate. So sometimes these can be hidden from our view, just depending on the other pathologies that our patients have. Common hepatic duct, less than 4 millimeters in your book. Out in the real world, we use 3, and wherever you are, wherever you end up. And then CBD, your book says 6 millimeters or less, but our book uses 3 millimeters within normal limits, WNL, within normal limits, magic. And then we give an additional millimeter per decade.
For our boards, are they gonna like measure this stuff? Is it gonna be like what our book is saying?
There's no standard. So they'll ask you like a range. They'll ask you like, it's 17 millimeters. Yes, it's abnormal. But if they're like 12 to 13, they're not gonna ask you like, is it 12 or is it 13? You know what I mean? They're gonna, it's gonna be, they're gonna ask you kind of off the charts. And the more you guys do exams and work with worksheets and scan patients, the more these, like, you don't really have to memorize kidney size, but I know, like, they're usually like 9 to 11, somewhere in there, just because they scan them so much. That's what I've noticed is 9 to 11. So it'll get to be more a little bit like something you work with versus like, here's what they should measure, it'll get easier. Okay, biliary obstruction. So we could have jaundice, pruritus. What is pruritus? I'm itchy. I have itchy skin. God, you're getting really good at this. Okay, and then right upper quadrant pain, and just depending again, biliary outflows, especially outflows if we start to see some liver damage. So 3 common places. Intrapancreatic, so this is where we have a stuck stone at the ampulla vater. We have a pancreatic mass that's compressing on our common bile duct, something like that. Subpancreatic, so that's between the distal and the proximal extrahepatic ducts. So somewhere in there we've got obstruction. Adenopathy, so that is lymph node abnormalities, so lymphadenopathy or adenopathy. So that's where we have enlarged lymph nodes, they might be compressing on our biliary duct, or we could have malignant masses. Portohepatic, so at the portohepatus, and there's malignant masses that can occur, and then there's something very specific called a Klatskin's tumor. And that occurs between the right and left hepatic ducts. So it's we drew yesterday, we had that. Here's our liver. So here's, so we have that right and left hepatic duct. So left hepatic duct, right hepatic duct, common hepatic duct, and so on and so forth. And you'll get a tumor right between these two. It's called Klatskin's tumor. It's very specific to that. In addition to causing problems with your biliary tree, who else is right next to those right and left hepatic ducts?
The portal triad.
So right and left portal veins as well. So we could also get compromised flow in our portal veins if that Klatskin tumor gets large enough. Okay, so here we kind of saw these before. So we've got that main portal vein coming in, common bile duct, so it's that shotgun sign, double barrel sign, or the abstract sign. And so there's going to be a bile duct, a dilated bile duct right next to a portal. Questions on that so far? Okay, next up, cholangitis. What do we think this is? Oh, geez, okay, never mind. What is it? You're right! How amazing! Yes, okay. So cholangitis is inflammation of the bile duct. We don't measure biliary duct walls, we measure the overall duct kind of width itself. So if I see a bile duct, we're doing CBD, my calipers go here to here, I'm measuring the actual duct. But if I see a thickness to this wall, it kind of looks like this, I may throw some calipers on it just to see the wall thickness. Not that there's an absolute measurement for it, but we're just going to say, hey, the wall looks very prominent, measuring 1.2 millimeters. And the radiologist can figure out what he wants to do about that. I would still measure my entire duct, yeah. Still measure the duct, but I'd be like, but the wall here is very thick. What's going on here? Okay, so these are all going to appear fairly similar. It's basically infection of, inflammation and infection of the bile ducts for many different reasons. Most commonly, ulcerative colitis. What is ulcerative colitis? You hear about it on TV. Oh, I'm going to go play on the playground. I'm going to take this medicine to keep my ulcerative colitis. So basically, it's inflammation of the colitis. So it's inflammation within the digestive. It's infection and inflammation within the digestive tract. So this is coming from the duodenum. So creeping up the duodenum through the ampulla of Vater into the biliary tree, and then causing inflammation and infection of the biliary tree. Okay, malaise. What is malaise? It's like having malaise. It's like when I have a hangover, I'm like, I don't have a hangover, I have malaise. But it's that general feeling of unwell. Just don't feel well. Fever, sweating, shivering, shock is severe. May have pneumobilia. Why? So we associate pneumobilia with an infection in the biliary tree. So why would we have pneumobilia with this?
Because it's an infection of
Infection of the biliary tree. You got it. Okay, so here we go. This guy around, kind of showing the stone here too. Can you guys see how kind of prominent and thick this biliary wall is? And it looks almost like the wall of that chronic cholecystitis, where that kind of has that hypoechoic layer within the wall. I guess that was all I cared about. Any questions on that? Okay, cholangiocarcinoma. So this is like carcinoma of the gallbladder, except it's happening in the bile ducts. It's very slow, whereas that one has late detection and high mortality rate. This one's very sluggish, very slow. Not that we want it to happen. So cholangitis, choledochal cyst, our patients are going to have those cancer indications. What are some of those cancer indications? Fatigue, weight loss, weight gain sometimes, splenomegaly, postprandial pain, GI changes. And so it may see a mass or at least an abnormal wall within the lumen or within, like the actually got the mouth.
It's good time to drink.
Hang on there, Carl. It's really hard to yell this long.
Mm-hmm.
It's one that kids are probably used to it, like yelling at children all the time. Okay. So same with any cancer that we're gonna see, we're gonna look for infiltration, right? It wants to creep into its neighborhood and cause problems all around. So here we have some, it's actually within the liver. So bile ducts that have become carcinoma and now it's starting to infiltrate the liver itself. Okay. Questions on biliary pathology?
Oof.
Okay, mini case review. Get out your scratch paper. This is not graded. You can screw this up as much as you want. Not turning it over.
Do you need paper?
I know, I'm just gonna type it in, thanks. Oh no, I'm just gonna type it in. Thank you though, appreciate it.
Okay. Ready to party? So I think for the end of this, I'm just gonna have you guys do a little rap report. Let's move on. Okay. So 55-year-old male, right upper quadrant, ordered for right upper quadrant pain, no prior imaging. What can we ask our patient? What might we see? Shout it out. This is like group activity. How long has it hurt?
Where does it hurt?
Where does it hurt? Location, duration. And I have no good news for this. Okay, let's make this up as we go. I have been having. Do I have the answers for this? No, I don't. I have been having right upper quadrant pain for 2 months, and it's most severe right under my rib cage.
Does it happen after you eat or?
It really gets worse after I eat. Yeah, yeah. You mean postprandial? Yeah. Okay. I have had a tubal ligation in 2017. Although she's like 55, I'm just doing my history now. Tubal ligation? I have a tube tied. Zip, zip, baby, zip, zip. Is that relevant? Not at all. Okay. But she hasn't had any procedures, so you're gonna hear stuff that isn't relevant, right?
Do you have fever?
No fever.
Vomit?
I ate at 5 a.m. I'm NPO 6+ hours.
Do you have nausea, vomit?
No, no nausea and vomiting.
No losing weight?
Nope, no recent weight loss.
Okay.
Weight gain or chocolate milk.
Any other symptoms that you think might be relevant?
No. No. What do we think we might see so far? So far we have 2 months of right upper quadrant pain, postprandial. I'm in my 50s, but I'm fair. I'm still kind of fertile, I guess. Fertile. Female.
We need to ask about pills.
Pardon me?
Do we need to ask her about pills?
About pills?
medication.
155. Sip, sip. I'm not on birth control.
Yeah.
No birth control.
Yeah, you're right.
Use it for other things too.
Okay, what do we think we might see so far?
Stones?
Pardon me? Cholelithiasis, dude, like our top 3. Cholelithiasis? Maybe cholecystitis? Maybe choledocholithiasis?
Yeah.
What are we thinking? Top 3? Okay, so we go through, we scan. Oh my, what is going on here? What is going on with this liver?
A little bit fatty. No?
What?
A little bit fatty.
Well, okay, alright. Let's see, let's put some color on it. Max! Oh my god, you're trying to kill me already? No, no. The ducks are bigger than they need to be. What did we call? I wish I knew. I wish it was like I had a whole PowerPoint on that or something. I just can't remember. Say it loud. Intrahepatic ductal dilatation. Okay, so what have we seen so far? So what are we gonna do next?
Take out the liver and then, or
Yeah, brain
gallbladder
transplant.
and then
Okay, we're doing
get that stone out.
Biliary tree.
So what do we need to look at? Where do we need to go?
Look downstream.
What's downstream? What does that mean?
Pancreas.
So we're gonna go from here to the pancreas?
Yeah.
Or we're gonna go follow it?
Yeah, yeah.
Okay, so what are we gonna look at on the way?
Gallbladder.
Gallbladder, what are we looking for gallbladder? Stones, walls, obstruction, so hydropic maybe. Okay, so we keep cruising, keep cruising, keep cruising. Oh my god, what? Oh, woo! So common hepatic duct, normal, abnormal. Common bile duct, normal, abnormal. There we go. Okay, so we keep cruising. Where are we going this time?
Down towards the
Pancreas or distal CBD? Oh no! What is happening?
stones,
What's our magic word for this?
like
Choledocholithiasis. You got it. Okay. So think about real quick, writing up just a real brief rad report. So I'll give you some measurements on things here. So I'm a 55-year-old female. Sorry. Five-year female, right upper quadrant. We know this so far, and we found our common hepatic duct. 7 mm, common bile duct, 19 So think about how you would speak to your radiologist about this. Post what? Prandial. What, you can't read that? Oh, really? Oh, I'm so sorry. Wait till you get your homework back. I feel so bad for you guys. You haven't had me write anything yet. And then some I'm like, I don't even know what I wrote. Let me just erase that and make it a little more readable. Like, good luck, guys. Let me know if you have any questions. Terrible handwriting. Seven. 19. 45. 40,000. Get like if you were to call him on the phone and say like, hey, this is what I got going on, bro. I'll talk to your radiologist about that. I'm not allowed to, you don't have street cred yet. Yeah. I do. But yeah, so descriptors.
This was on the desk up front. Do you need it? Okay. I just didn't want to throw it away if you might need it.
And then Shea, on your report, when you said, I noticed intra and extrahepatic ductal dilation, the intrahepatic dilation was noted on the view of the right liver lobe. Is that where you're seeing it?
We just saw it, so I didn't get that specific, but out in the real world you could, like near the porta hepatis or near the right liver lobe or near the left liver lobe.
So when you're talking about like street cred and stuff, so we're allowed to use those terms?
You could say intrahepatic ductal dilatation because that's the only thing it will ever be.
Oh.
But where it's like, you know, choledocholitis, well maybe it's a mass, maybe it's whatever. And you guys are in that kind of funny gray area where eventually you'll be able to say choledocholitis. But right now I want you to work on the terms. And you never really describe like anechoic tubular structures adjacent to bile ducts or adjacent to portal veins within the liver. You just call it intrahepatic ductal dilatation. So it will never be anything else about that.
So when you're looking at this image, can you just describe what you're seeing? Yeah.
So the cat scratch.
Oh, the cat scratch signs.
We normally see, you've seen portal veins as they go through, and they're kind of like, you know, they kind of branch out, but they're never like very tortuous and large.
Mm-hmm.
And in this case, we're seeing kind of tortuous, large tubular structures.
Okay.
And especially when we put our color on, so we're seeing that they're adjacent to portal veins and they aren't lighting up.
Okay.
Excuse me. So why aren't they lining up?
These are bile ducts.
Oh. So those are bile ducts, and then.
So remember intrahepatic and extrahepatic ductal dilatation. So they're going to run that portal triad, hepatic artery, portal vein, and a bile duct. And we don't normally see anything but the portal vein in the liver. Everything else is really small. So if we're seeing those dilated, those are dilated ducts. We've got obstruction downstream. Does that make sense? And then extrahepatically, that would just be, hey, our common bile duct should measure this, and it's measuring larger than it should. So we're going to see a bunch of ducts outside the liver. We're just going to see that main kind of extrahepatic ductal area. So whether it's common hepatic, cystic, gallbladder, or common bile, it's just going to be bigger than it should be. Whereas in the liver, there's such a kind of true branch and dilate.
And that's those echogenic walls that we noticed besides the vascular, the vascularity there.
Echogenic walls, that's just a feature of them being flat to our beam.
Oh, okay.
It's like if you look at these ones, There's some in here that don't have echogenic walls because they are flat toward beam.
Okay.
So that's just a feature of it being flat. It's more about that we have anechoic tubular structures within the liver that don't light up. We shouldn't have those. Those are ducts being dilated.
Okay.
Sorry about that.
Measurement because there's 19.
So yeah, I just said that, yeah, you could if you wanted to, wouldn't be against the rules, but I just figured common guidelines 19, so they know that, and since we have intrahepatic ductal dilatation, it's implied that the whole thing is dilated. Okay. But you wouldn't be wrong to do that. Okay. Okay, you ready to go over this together? Sure. There are no stupid questions.
I'm
Just
hearing
stupid Walmart.
dilation and ductal dilatation.
Same thing. Some people say dilation, some say dilatation. I don't know which one I say. I probably use it interchangeably.
I was getting confused, I didn't know if there were two different things.
Okay, so were all of your round reports pretty similar to this?
No.
Oh, these comments. So Dr. Phil, who's probably the worst doctor in the world, whatever. Okay, anyway. I have a right upper quadrant exam for you. We have a 55-year-old female presenting with right upper quadrant pain for the last 3 days. I lied. I think I said 2 months. During the exam, I noted inter and extrahepatic ductal dilatation with a CBD measuring 19 millimeters. There were 2 stones obstructing the distal CBD at the level of pancreatic head, largest measuring. We have measurements for it, so whatever it would be. The stones were immobile with position change, and the patient was tender when that area was. Sound pretty good?
Did you add anything about the patient was NPO for 6+ hours?
Well, we didn't include any gallbladder stuff. So if I had like a contracted gallbladder, I would have said patient was NPO, but we just were more concerned about the stones in the duct. So what's our pathology? All right. So what was it about this patient that pointed you in that direction initially, without seeing the images? Pain, right upper quadrant pain, postprandial pain. Female, right? Fair. That is a tough no. Yeah.
Why didn't you include the common hepatic duct?
Well, yeah. So Becky brought that up. I probably could have, but I am told because there was intrahepatic ductal dilatation and extrahepatic, it was just implied that it would be dilated.
Oh.
You wouldn't be wrong to include it. Yeah. That would not hurt my feelings.
What is stones? Would you rather us like define the stones, like well defined?
So stones are funny because they're always well defined, if that makes sense. You don't have to use the V's, love, so it's usually stones just end up being echogenic shadow foci. That's kind of the generic way to talk about stones.
So for our homework, if we have to do that, you'd rather us have the longer description than identifying it as a stone?
Yes.
Okay.
Yep. Terminology. So if you have a pathology that you're writing up and say it's kidney stones, you're going to say nephrolithiasis or echogenic shadowing foci seen within the pelvis of the right kidney measuring 2 centimeters. Causing obstruction. And hydronephrosis. And hydrourethria. We'll get there.
Are you always going to be calling and reading this?
No.
Or you would write a report?
So those worksheets are the big thing. So the worksheet gets uploaded into my patients. So all the images I've taken, upload my worksheet. It has all my verbiage on it. I've got street cred, so I can say choledocholithiasis. You guys will have to describe it. And then there are a few things that we have to call on that are surgical emergencies, ectopic pregnancies, torsion, any fetus in the 2nd or 3rd trimester without a heartbeat. So there are certain things that we absolutely have to call on. And the rest of the time, they just get put into packs, and a radiologist will pick them off the list and read them. So I may go a whole 4 shifts without ever interacting with a radiologist, which is fun.
So say you know you have enough street cred to use the dictionary.
When you get hired, or when you feel like you have enough street cred. But as students, you guys have to, because you're gonna run into shit that you don't know what it is. I have like this testicular mass, and I don't know, it looks like a smiley face with a ball cap on. I'm like, I have no idea what this is. So you just describe it, give the location, and it's up to the radiologist to piece it together. So it's more getting you guys used to using the terminology. So there are times when I'm like, this echogenic shadowing thing with mobility within the spleen, surrounded by a hypoechoic vascular halo. What is it? Some like weird sarcoma that only happens in Guam, or whatever. And so there are stuff that you don't run into.
Would you call it a thing?
Structure. Structure, mass, lesion, I go with structure a lot, 'cause I'm like, structure. That works. Yeah.
On the report it says the stones are showing the distal CV at the level of the pancreatic head. Can you show us on
Sure.
the thing how you found that out?
So when we go back to this image, so this is gonna be my porta hepatis, IVC, gallbladder. This is gonna be more towards the pancreas. You guys don't quite recognize pancreatic tissue, but this is pancreatic tissue right here. This is the contour of the liver between the pancreas and the liver.
Okay.
You just point out there that with your.
Can you take us one more time from, is that superior to inferior? So right to left?
Okay, so we did our right liver lobe, and we saw these, kind of what we call the cat scratch sign. We didn't have color on it yet, so we didn't quite know what we were looking at. You can see there's dilated anechoic tubular structures throughout the liver, which shouldn't really be there. And then we put color on our right liver lobe, and we saw that these didn't light up. Now, we shouldn't see biliary ducts in the liver unless they're dilated and something's wrong. Normally, we don't see them at all, right? They're so small, they're that really kind of microscopic level. And so if we're seeing these in the liver, adjacent to portal veins, I know that it's part of the portal triad, and I know that it's a dilated duct. So we had intrahepatic ductal dilatation. So that tells us that we need to investigate downstream. So we're gonna go to the common hepatic duct, evaluate cystic duct, gallbladder, and then continue down to the common bile duct and pancreatic head. So we went downstream, we went to the common hepatic duct, dilated, common bile duct, dilated, we went further downstream. So this is these are all different cases. And then here's our common bile duct terminating at the pancreatic head, and we have 2 stones at that distal common bile duct. So we just went downstream. We started with the liver and just continued downstream.
Thank you.
I could have included like a gallbladder image showing that it was normal, but I didn't think to do that. I was too late.
Shea, can you please show us the pancreatic head in your...
So panc head is right in here.
Just this part. Thank you.
And then this is liver over here. And if you look at it, it's distal, right? Porta hepatis, it goes that way, it's distal. Okay, questions so far?
Oh,